Hello, my name is Stacie Deiner. I'm an anesthesiologist from Dartmouth Hitchcock Medical Center in New Hampshire in the United States. I'm the leader of the Brain Health Initiative for the American Society of Anesthesiology, and I'm here to talk to you about anesthesiologists and how we can be leaders to improve perioperative care for older adults. Uh, I think anesthesiologists are always a little disappointed when this talk doesn't focus on the choice of medications or monitoring the brain. But in truth, our best way to take care of older adults is to be good partners with the surgeons and also the medical doctors who take care of older adults prior to surgery. And so recently, the American College of Surgeons created something called the Geriatric Surgery Verification Program, which is a quality improvement program to ensure that risk assessment and measures to prevent delirium and falls and better transition home is taken care of in a proactive way, starting when the patient is considering whether to have surgery. So I'm going to tell you a little bit about this program today. The details of how to do the program in your hospital are available for free online by Googling ACS, Geriatric Surgery Verification Program, and you can download a PDF that will have most of the information that I'm going to tell you about today. So the GSV program is systematically to improve surgical care and outcomes for older adults by enrolling the patient, but also the family, to understand what the surgical process is going to be like and the need for additional support after surgery, and also true reporting about what's going on prior to surgery. Is the patient forgetting things? Do they need help getting around or taking care of themselves or their home? The program also encourages interdisciplinary input and collaboration. So, can we work with the patient's medical doctor to know that the patient is having surgery and make sure they're prepared, and hold any medications that are appropriate and make sure they start taking, say, cardiac medications they may need to start taking again when they go home. And the program also encourages implementation of evidence-based practices. So I'll tell you a little bit more about that. So the GSV has, went one ahead, quite a few standards. There was a literature review from 50 stakeholder organizations, including patients and families and health professionals and medical surgical specialties. And we came up with 92 initial standards. And then with a literature review, we actually came up with 308. And from that, we all agreed on the most important 30 of those. And so there's been a pilot study in 15 hospitals across the United States to actually roll out these standards. And currently, the program is in use across the United States. So the most important thing, the number one, is that you have commitment for older adults from the people who are leaders in your hospital, that they recognize that older adults are going to need extra support in order not to have complications after surgery. The saying in anesthesia is that pediatrics are not just little adults. Well, similarly, older people are not just the same as adults in the middle of their life. There's a lot of physiologic things that are different as you age, your ability to clear drugs, many things about how your heart will deal with fluid around the time of fasting. So we need institutional buy-in to help support our older adults, because there's a lot that's going to need to come from nursing and care managers to make sure that patients get the support they need. There are facilities recommendations, personnel and services. I think anesthesiologists go right into, protocols, but we also have to remember that we're an important part of quality improvement systems, and we can also work with community doctors. And, many of us as anesthesiologists are also interested in basic and clinical trials. And as you build these programs in your hospital to take care of older adults and you start to measure things like cognition before surgery, frailty, and delirium, this also gives you an opportunity to do research to understand how whether patients do better or worse with certain techniques or interventions, since you know how to do the screening in any case. So the GSP rolled out to 5,000 hospitals, and it's being done in community hospitals here and also academic places. The target population is patients 75 years and older and who are going to be surgical inpatients, because these are the patients who have the highest risk for mortality and readmission. When we look at our data, especially in the United States, we're still doing major surgery on patients over the age of 75. I think 25 years ago in the United States, we didn't take older adults for the kinds of surgeries we do now. It's not uncommon to see older adults have very large spine fusions, abdominal surgery procedures, cardiac surgery, joint replacements, and we need to adjust our care to recognize that patients today who are coming for these surgeries are much older than they were when, say, some of us trained 20 years ago. So the first and most important standard is about patient expectations. So if you're over 75 and you have a planned inpatient stay, we mandate that we know the code status for each patient. So we ask each patient how they would feel about being resuscitated in the United States. We give them a choice, and we also have advanced directives. Would they want any kind of extended measure should they have a complication from their surgery? It's always interesting to figure out how to navigate these conversations without scaring or upsetting patients. Just because we're talking about what you might want if you have a complication doesn't mean we believe that you're going to have a problem. And who's the person's medical proxy? Is it one of their children? Is it a spouse? In some cases, if the patient is very sick or potentially has cancer, it may be appropriate to involve palliative care doctors to talk about how to keep the patient comfortable and manage their symptoms. And it's interesting, in the United States, I think we do put a lot of older adults in nursing homes, but that's not to say that older adults enjoy being in nursing homes. And so this slide shows a study where they asked patients what would be their preference if they knew they had to go to a nursing home after surgery. And you can see that 30% of them said they'd rather die, and 26% of them were very unwilling. However, a lot of patients, at least in the United States, cannot go back to being home or living on their own after surgery and need to spend at least some time in a nursing home, which sometimes is not in line with their wishes. And so talking to them before surgery about how likely they are to have complications and where they'll go after surgery is incredibly important. So vulnerability screens are things that can often be performed by the anesthesiologist or can be done at the surgical clinic prior to booking for surgery, or some sort of a collaboration between the two. Patients who are 75 years and older are at risk for impaired cognition, which is a risk for delirium after surgery. It's also important to screen patients for their functional status. Someone who's very active at home and is able to exercise and lift things is much less likely to have a problem than someone who requires help getting dressed. Malnutrition can be an issue. Sometimes it's not just access to food, but sometimes their appetite is not very good, or they have dentures or no teeth that makes it difficult to eat well. Some patients have difficulty swallowing. And I think we mentioned the preoperative palliative care assessment. So this is an example of some screening tools that one of my colleagues built into the electronic record to do a preoperative cognitive screen, frailty screen, and functional screen. At the top, is the recommendation to do a mini-cog test. Mini-cogs have been used in a variety of preoperative testing settings, and so a cutoff score of less than 2 or less than 3, depending on how sensitive you want to be, defines patients who likely to have preoperative impaired cognition, but also more likely to have longer length of stay and falls after surgery. Frailty, they measure as gait speed, although you can measure it in many different ways. There's something called the Frail scale. There's a clinical Frail scale. There are physical measures like timed up and go. You time how long it takes a patient to get up from a chair and get started. There are many ways to measure frailty, and no one knows which one is the best. But consistently in studies, patients who are frail have an increased risk of complications after surgery. So it's an important thing to screen. They also ask about function. These are what's called basic activities of daily living. Can you get out of bed yourself? Do you dress yourself? Can you make your own meals and do your own shopping? And in this model, the score of all the different components will tell you whether the patient is a high, medium, or low risk. One of the program standards is pharmacy review. It's common in our system for people to come in with older adults to come in taking many medications, not always to know all of the names of the medications or be taking them correctly. Reviewing the medications a patient's taking before they come for surgery is very important to avoid drug-drug interaction, but also to make sure that you are administering the drugs that they need and not those that are contraindicated in the perioperative period. And also to make arrangements to make sure the patient understands when to start those medications that may have been discontinued after surgery. You can create standard order sets to prompt better care for your older patient. The American Geriatric Society every 2 years updates a list called the Beers criteria. And so Beers criteria are medications that are contraindicated in older adults for a variety of reasons. And there's about 15 to 20 of them that are things we commonly use in anesthesia that are not recommended for older adults. Benzodiazepines are in there, scopolamine is in there, diphenhydramine is in there. So it's important to familiarize yourself, and the Beers medications are free publication that you can access online. Most order sets for older adults are opioid sparing, so we try to minimize the amount of narcotics we give older adults. But of course, both the lack of control of pain, but also severe pain can cause delirium. So, the great irony is that you still have to deal with someone's pain after surgery, and someone who's in pain doesn't engage well with their environment and they easily become confused. And so that opens the door to multimodality pain management. But here you have to be careful because for older adults, higher doses of drugs like gabapentin can make patients dizzy and a fall risk. And so you should consider carefully whether that's the appropriate medication for the patient, or even if you give it, can you give a lower dose? Ketorolac might be a challenge for an older adult who has renal problems. So you're going to be very thoughtful when you choose your pain medication regimen, not just for opioid sparing, but also when you choose your multimodal agents. Delirium screening is a requirement of the American Geriatrics verification program. And so looking to understand which of your patients are confused after surgery is incredibly important. And anesthesiologists can be leaders to educate nurses and other doctors how to screen patients for delirium. And delirium, I always like to say, is very much like a stress is the equivalent of having ischemia on a stress test. So if a patient's body or mind is stressed and they become delirious, It's like a patient with coronary artery disease who has ischemia on their stress test. You have to find out what is the underlying problem. Is it a medication? Is it pain? Are they bleeding? Are they becoming septic? Is there something wrong with their blood pressure management? Delirium is an emergency until proven otherwise, and so that awareness is very important. But you don't know it if you don't screen patients, because 40% of delirium is hypoactive, and what that means is the person is just quietly confused, and so it can be very easy to think that they're just relaxing. So you should use an approved delirium screen to try to identify patients who are delirious after surgery. Other postoperative standards include the need to help patients ambulate, but also to prevent falls, prevent pressure ulcers, encourage nutrition and hydration, making sure food and water is easily within their reach, but also that they have dentures back so they can chew. And interdisciplinary care for the highest risk patients, if you have access to geriatric specialists, this can be incredibly helpful if you're managing difficult patients, like patients who have come in with emergency hip fractures. We've also started to focus on transitions of care, and by that specifically, I mean the time at which the patient transitions to going from the hospital back to their home. And this is another important time to do medicine reconciliation. The patient may have been taken off of certain meds during their time in the hospital. They may need to either continue those meds or not. There may be meds that they were taking at home that need to be reinstated. And so it's so important to be as thoughtful in discharging a patient as when you have them admitted to your service. Communication is incredibly important, and if it's possible to have opportunities to connect with the patient's primary care doctor, this is incredibly useful. And if they have a way to reach you or your hospital or your department if there are questions, this also can be incredibly helpful. At least in our system, it can be quite difficult for even doctors to connect with each other at our big facility. So establishing a way by which you communicate, either a hotline or an email, can be very helpful. And there's varying quality of the types of rehabilitation facilities that patients might go to after joint replacement, but it's incredibly important. We've created a cheat sheet type program where we give a one-page summary of what's happened to the patient during their hospitalization to a rehabilitation center, so that they can quickly look at that one page and know what's going on with the patient. So our handoffs are very important as well. Where I live in New Hampshire is one of the oldest states in the United States, and patients over 75 are 20% of our inpatient surgical population, and they're 1/4 of our orthopedic surgery inpatients every year. Before we started this program, we saw that the older patients stayed 2 to 3 days longer than CMS, our hospital governing body, expects for hip replacements. And the trend continued across other surgical services for this age group, and we weren't totally sure why. So what we've been working on is implementing screening older adults for cognition, frailty, and social determinants of health. So issues about transportation to get home, safety being the home, help at home. And we do all these things before surgery when we first see the patients, so that we can make a plan for them instead of waiting till they have some sort of a problem when they're an inpatient and then trying to make a plan, because that delays their discharge going home. We're lucky enough to having an aging resource center, which is a center and a group of nurses that helps talk to patients and connect them with help in the community. We're working with a digital media innovation startup company to give educational materials both to the doctors and also to the patients. And we're working with our care management services that help patients plan for going home and geriatricians. And in our system, we also have something called community health workers who actually go to patients' homes and can go visit them afterwards to check on how they're doing. And they're best suited to address non-clinical needs, such as whether there are fall risks in the home. So, thank you for all the people who help us. The picture here is what our hospital looks like in New Hampshire, it is the most rural academic center in the United States. So outside the campus of the hospital, you'll see that there's a forest, and because that's where we live, which has its own set of challenges. So thank you so much for this the opportunity to give this presentation, and I hope you enjoy your conference.